Now, these were some organisms which can cause infective endocarditis in different population of people. So the most common cause of endocarditis in people with poor dental hygiene or following a dental surgery is viridin streptococci. In patient with colorectal cancer, it is Streptococcus bovis. The most common cause in general is Staphylococcus aureus. The most common cause after prosthetic wall surgery is Staphylococcus epidermidis. While the rare causes can include Coxella burnetii, Bartonella, Brucella, and Hesse group, which include Haemophilus, Actinobacillus, Cardiobacterium, and Echinella, and Kingella. Now, how we are going to diagnose a case of infective endocarditis? Infective endocarditis is diagnosed on the basis of modified Duke criteria. What is modified Duke criteria? For the diagnosis of infective endocarditis, two major criteria. Either two major criteria should be present, or one major and three minor criteria should be present, or five minor criteria should be present. What is a major criteria for the diagnosis of? What are the two major criteria for the diagnosis of infective endocarditis? Remember that the first major criteria is positive blood culture, and the second major criteria is positive echocardiogram or evidence of endocardial involvement, that is positive echocardiogram. So what is the criteria for positive blood cultures? Two positive blood cultures showing typical organism consistent with infective endocarditis. Remember that the typical organisms for infective endocarditis are Streptococcus viridans and Hesse group. So two positive blood cultures showing typical organisms that are consistent with infective endocarditis. So typical organisms that are only associated with infective endocarditis, they include viridin streptococci and Hesse group. While if there are
Sir,
atypical organisms,
it's not Staph aureus.
Staph aureus can cause other infection as well.
Okay.
Staph aureus does not only cause infective endocarditis. Staph aureus can cause pneumonia. Staph aureus can cause skin and soft tissue infection. Staph aureus can cause food poisoning. So Staph aureus, basically Staph aureus and Staph epidermidis, they cause a variety of other infections. So they are not typical for infective endocarditis. In case of infective endocarditis, the Staph species are taken as atypical bacteria. The typical bacteria for infective endocarditis are Viridin streptococci and Hesse group. So two positive blood culture with typical bacteria and three positive blood cultures, three or more positive blood cultures where the pathogen is less specific, such as Staph aureus and Staph epidermidis. So for Staph aureus and Staph epidermidis, there should be three or more positive blood cultures because they are not specific for infective endocarditis only. They can cause other infection as well. So this is the first major criteria, that is positive blood culture, two positive blood culture for typical organisms, and three or more positive blood culture for atypical organisms. Now the second major criteria is positive echocardiogram. What is a positive echocardiogram? Positive echocardiogram means on echocardiogram there are oscillating structures, or there is abscess formation, or there is new valvular regurgitation, or there is dehiscence of prosthetic valve. This is called positive echocardiogram for infective endocarditis. So if these two major criteria are present, then it will make the diagnosis of infective endocarditis. Now, if one of the major criteria is present, either positive blood culture or a positive echocardiogram, either one of them is present, then to make a diagnosis of infective endocarditis, three minor criteria should also be present. Now, what are the minor criteria for the diagnosis of infective endocarditis? The first minor criteria is a predisposing heart condition such as rheumatic fever or a congenital heart disease or a prosthetic heart valve or intravenous drug use. So this is one minor criteria. The second minor criteria is that microbiological evidence that does not meet the major criteria. Fever more than 38 degrees centigrade, vascular phenomena and immunological phenomena are present. What is vascular phenomena? Vascular phenomena is that thromboembolism, emboli, which can cause splinter hemorrhages, JNV lesions, petechiae or purpura. What are splinter hemorrhages? Splinter hemorrhages are basically linear lines on the nails. JNV lesions are painless macules or papules that are present on the palms and sole. They are painless. Remember that JNV lesions are painless while osseous nodes are painful. Both of them are present on palms and soles. JNV lesions are nodules or macules that are painless, while osseous nodes are painful. And JNV lesions are due to vascular phenomena, and osseous nodes are due to immunological phenomena. Immunological phenomena means there's deposition of immune complexes, deposition of antigen antibody complexes, which can lead to the deposition of antigen antibody complexes in the glomerulus will lead to glomerulonephritis, and the deposition of immune complexes in palms and soles will result in painful nodules, which are called osseous nodes, and the deposition of them in the retina in root will center. So the minor criteria for the diagnosis of what are the five minor criteria for the diagnosis of infective endocarditis? First one is predisposing heart condition or intravenous drug use. Second one is microbiological evidence that does not meet the major criteria. Fever more than 38 degrees centigrade, splenomegaly, splinter hemorrhages, JNV lesions, petechiae or purpura, and glomerulonephritis, osseous nodes or root spots. So these are five minor criteria. So if all five of them are present, then it will make the diagnosis of infective endocarditis, or any three of them along with one major criteria such as positive echocardiogram or a positive blood culture, then it will make the diagnosis of infective endocarditis. So the initial investigation, if you are suspecting a diagnosis of infective endocarditis, is blood culture, and the next investigation is echocardiogram. Now the diagnosis of infective endocarditis is confirmed. Now what is the treatment of infective endocarditis? The treatment of infective endocarditis includes, now the treatment depends upon the type of valve. If native valve, then the treatment is different, and if prosthetic valve, then the treatment is different. What is the treatment for native valve endocarditis? Amoxicillin plus low dose gentamicin or vancomycin plus low dose gentamicin. When you will use vancomycin in place of amoxicillin, the first indication for vancomycin is penicillin allergy. If there is penicillin allergy, then in place of amoxicillin, we'll use vancomycin. The second indication is MRSA. If methicillin resistant staphylococcus aureus is suspected, then vancomycin will be used along with low dose gentamicin. And the third indication for the use of vancomycin is severe sepsis. So in these three conditions, we'll use vancomycin along with low dose gentamicin. Otherwise, we'll use amoxicillin. Now, if there's a history of prostatic valve, then we will use rifampicin along with vancomycin and low dose gentamicin. So, a fourth indication for the use of vancomycin is prostatic wall endocarditis. And the new drug rifampicin will also be used. So, this was all about the diagnosis and treatment of infective endocarditis. I hope it's clear to everyone. If there is any question, then you can ask.
Sir, can you please repeat the treatment?
Treatment is simple: amoxicillin plus low dose gentamicin. Amoxicillin plus low dose gentamicin if native wall endocarditis, and if there is allergy to penicillin, or if MRSA species are suspected, or if there is severe sepsis, then we will use vancomycin in place of amoxicillin. And in case of prostatic wall endocarditis, we will use vancomycin plus gentamicin plus rifampicin.
Okay, sir.
Any more questions?
So for prostatic wall, we use vancomycin also with gentamicin.
Gentamicin will be used in all the cases.
So in this we add rifampicin as well.
Yes. In prostatic wall, we use rifampicin as well.
Okay. And this should be like 7 to 14 days or longer.
Antibiotic treatment are usually given for 4 to 6 weeks.
4 to 6 weeks.
Because in
Okay.
infective endocarditis, the antibiotic treatment is required for longer duration, at
Okay.
least 4 weeks and maximum 6 weeks. Treatment can be given.
Okay.
Any more questions? So our next topic is heart murmurs. Before we discuss different types of heart murmurs, can everyone see the diagram?
Yes, sir.
Hello everyone. Can everyone see the diagram?
It disappeared.
Uh, does it reappear again?
Yes, can see now.
So before discussing heart murmurs, you should know the areas of auscultation for heart murmurs. There are 5 areas, but you need to remember 4 areas which are important for Plab 1 exam. As you can see in this diagram, area 1, area 2, area 4, and area 5. Area 3 is called Ebbs point. Ebbs point is basically the center of heart